my obligation was to show the interpretations of cytology and histology, but I would prefer to rather tell something about tissue interpretation, but also my experience, our experience as a group to improve accuracy of FNA samples. So I will just briefly mention the biology and classification of pancreatic cancer, and then go on with interpretation and processing of the tissue, what we do, what our experience is, and what we can try to improve. Possibly it's good to remember that pancreatic cancer, ductal adenocarcinoma, does not arise from the ductal cells. It's most likely come from the acinic compartment. And the acinic cells, kind of plastic cells which can, upon inflammation and some other processes, de-differentiate or trans-differentiate to ductal-like cells. And I think it's interesting because it's possibly a process going on in other cancers as well. Like, for example, the Barrett's-esophagus. I think there are some similarities with pancreatic cancer and Barrett's-esophagus, also metaplasia. And the cells, the metaplastic columnar cells, lose the identity markers they had and then differentiate to some kind of other cells. And this what is likely to happen here in before the malignant transformation. So the ductal adenocarcinoma come most likely from the acinic component. And then once metaplasia is induced, the cells get other mutations, and KRAS mutation is, of course, well known. KRAS mutation initiates cancer but does not drive oncogenesis beyond this. So some mutations will come up later on and allow tumors to proceed to cancer. This information might be important for interpretation of results you will get from molecular studies or from your own experience. I don't know, many people nowadays use NGS in some cases to improve accuracy of FNA samples. So there is an attempt to classify ductal adenocarcinoma using expression profiles, whatever, and they found different subgroups. There were different classifications in the past. They all associate with pathological grade, and some have better prognosis or not. I think there are different types of ductal adenocarcinomas, but on histology, most of the ductal adenocarcinoma looks similar to each other. So we have some differences. This is an example of a cancer with, in the overview, you can see these large ducts. And if you look closer, you see the cells within the ducts, and they have some foamy cytoplasm and some irregular nuclei. This is the histology of the typical ductal adenocarcinoma producing mucin. And the other possibility is this kind of tumor, which is less well defined. The structures are irregular but small, and some parts of the tumor does not show any glandular structures at all. So no ductal differentiation. This is also typical of ductal adenocarcinoma actually to be heterogeneous within a lesion. So you can see in the histology different kind of differentiation. Why I'm showing this? First of all, we can, by histology, easily differentiate ductal adenocarcinoma from other types of pancreatic lesions like neuroendocrine tumor or acinic cell carcinoma, for example, etc. But on cytology, it could be difficult. And remember that most pathologists are trained as histopathologists and not cytopathologists. And they have seen much more histology than cytology, I think, in most pathology departments. And also the exposure of the pathologists to FNA samples specifically is not that high. So what do pathologists need actually to know and to differentiate on the FNA sample? They need to know how the normal ductal or acinic cell look like, and also need to know, of course, the cytology of the adenocarcinoma. But also they need to know how the contamination is looking like from gastric, stomach, duodenal parts. And they also have to differentiate ductal carcinoma from other lesions like benign neoplasms, etc. So historically we use smears for that. So FNA put on the smears, and the smear history is a long history tradition, right? The inventor is a Greek pathologist who actually trained himself over decades and developed an atlas. And this was based actually on pap smears or smears from his wife. And every day he took a smear of his wife and did it for many, many years, for decades. And then he was able to categorize the cells. And then he became a hero in his country. But why 200 years later do the smears? It's because of the costs, because of the diagnostic issues, because of the rows. But we know the rows is not very common in Europe. So this is the tradition, how we look at the smears. But, the first thing when you have the Giemsa stain smear is you have another kind of material, you have another kind of staining. For us histopathologists, it's a new stuff, right? It's another, less colored world, because we have blue and dark blue. We have the nuclei, we have the cytoplasm. It's difficult. It's a different kind of staining we have to interpret. But this is the normal ductal epithelial, and we train ourselves to recognize that because it's very regular and remembers Honeycomb. So you can appreciate the cells and nuclei next to each other and the margins of the cells. So that could be learned. But then, when it comes to reality, we have all kind of material, and this is good preserved material. So let's try to categorize that. What would you say about this sample? Yeah, experience. Really, yeah. That's not easy. This sample is showing cells with overlapping nuclei, right? And this is not the typical normal appearance. This is cancer, okay. But what to do with this? And then the histopathologists among us will really have some difficulties, because these cells are not looking like normal ductal cells, but also not looking like carcinoma cells. So we are in trouble. We decided these could be reactive cells, but the interpretation is difficult on the MGG smear. The other problem, do you know about that? It looks like good material. Sorry. You see these cells within the structures? These are goblet cells, right? The goblet cells pumping out here and there, and this is contamination. So this material comes from duodenal epithelium and not from the tumor and not from the pancreas. So the pathologist, the histopathologist, again has to differentiate these cells from other cells. And for many of experienced pathologists, the FNA samples might be new, and they would not recognize that. What about this one? It overlaps, some nuclei are overlapping each other, but this is normal acinic component, which you of course will see in a sample. So again, I think it's not easy. It looks the same, and for me, if I open the book of cytology and I compare the samples, I cannot differentiate one from the other, I'm sorry. And these samples really look very similar to each other, but this is cancer. So you have to be really trained in cytology and interpreting cytological specimens in a good way to do that. And also, what do you think, how many smears would have these artifacts? I think we thought it might be 30% or something, but then we had a study and then we found out it's more than 70% of the smears have some kind of loss of material behind the clots or behind something. So this material in this part of the smear is not sufficient, right? It's wasted. So we had the idea to do kind of smear study, smear training study, and then because the tradition is there, we should carry on, learn how to do better smears, and then we thought we will do a study. We will do a training and then compare smears before and after the training. And we invited endoscopy personnel and pathology technicians, everyone, to be part of it, and then we collected material after this training. And the smear procedure is really not that easy. So you have to learn it as well. You have the preparation, you have on-site assessment and staining, so it has to be perfect. So do you think these are different smears? Do you think there's one good smear? What is the perfect one? I think that one is good. And these are too thick, actually. The material is not dispersed equally and too thick. And then we had a training, video training, and because we had so many artifacts from smear, we made an instruction and showed how not to do it, because we think in this case, it's too much material. You see the clot on the slide. And sometimes the material is good, but then you stamp it and then destroy the cells. And sometimes somebody learned to do it in a different way. The sandwich is also from the literature. Some people do that. I don't think it's a good idea. Or this kind of material, it's also too much and wasted. So we made also a video how to prepare it properly. And it comes down to make a very thin preparation with very tiny material on it. Just a little droplet, like that, it's enough. And then smear it regularly. So this is how we would like to see them. So we thought if we go on and train everybody, then we will get perfect smears. And then we will improve the accuracy. Just with this simple, efficient method. So we organized a day with the training where we had around 20 people from 7 centers, and then we prepared together the smears and they learned how to do it. And then we collected material from these people after the smear and then compared with material before. And we thought it would be better, but it wasn't. It wasn't in when it comes to artifacts. Again, before the training and after the training, the same amount of artifacts, the same problems with fixation, degeneration, whatever, and the same cellularity issues, okay? And the exact numbers, I don't know yet. I know that we did not improve the accuracy by smear. Before and after the training, there was no difference. These are results in different centers, and there is no improvement in none of the centers. So the smears does not help. Then we look back in our data, and we looked back 10 years ago. We only did smears, and the results were bad. We had only 40% sufficient material back in 2009. And then we had the cell block and on-site assessments, and then the accuracy improved in 2012. And then in 2016, we have the registration with Bethesda classification, so 6 categories. And we have the cell block, and we now approaching 80–85%, I think, of the samples being adequate and with a good accuracy. So we thought the cell block will be better. And you saw this study already, it was shown previously. Somebody was thinking the same in the past. So what is the cell block? Cell block is just another way of processing tissue, right? You have the same amount of tissue, but you do another a staining. You treat it like being more histological material and put it in the machine for the H&E staining, right? And then I think the world is more colored because you have more details on the nuclei, you have more details on the cytoplasm, and this is the way how histologists are trained actually. So the daily histology is this histology. So we don't have to learn ourselves special things. So this is the typical cell block morphology. And actually we can, on this group, more or less make the diagnosis, especially because we have in the same sample normal cells, and these cells, the histologists will be more comfortable on making the diagnosis of cancer. And if you compare the MGD and cell block, you see the different world actually. And the MGD, again, often really not colored, but here you can see the nuclei and the cytoplasm more clearly, and also do the immunohistochemistry as well. And 10 years ago, we did not have the cell block, we had only the smear, and then we spoke to Cook, and we had the idea to do FNB on pancreas. I think it was not that common back to these days, and one way or the other, they developed the FNB needle, and then we had initiated this trial, which is now published. A part of this is published, another part will be published soon, where we had 600 samples with FNA versus FNB needle. It was a huge effort, and we have the result now, showing that FNB has a little bit better result than FNA. But still, the FNA result is good. It's around 80%. And when we look at the data, we see that the most diagnoses are actually from FNA samples are performed on a cell block, not on a smear. So this result of FNA needle of around 80% comes actually from the cell block. And of course, FNB needle is a little better, but still. This part is not published yet because we tried to show that the results which are published are more or less generalizable, and we gave the samples to many pathologists to look at to see if the inter-observer agreement is different for FNA and FNB samples. And so to Rotterdam came around 13 pathologists from over the world, and we looked at the samples simultaneously, and we had to make a diagnosis on FNB and FNA samples. There were academic and non-academic pathologists, and it seems like FNB needle has better agreement than FNA needle. And it does not matter whether you're expert or not expert, academic or non-academic pathologist. With FNB you go better, also in terms of inter-observer agreement. So the highest accuracy in the study we had was for FNB. So in our hands, we think the material is processing is the most important part. We still appreciate the smear because of the tradition. We do just one small droplet of the material on the smear, and the rest we put on a medium. This is cytolid in our case, but can be anything. All the hospitals around Rotterdam use different fixative, but it does not matter, I think. The cells are well fixated in a medium, and then you can go on and do something else. And of course, you take out the microbiopsies and do the histological processing of it. And we do the cell block with microfragments. It does not really matter which technique you use. There are different possibilities to do the cell block. We have the automated system, but you can also do it manually. It does not matter. The other initiative comes from the GI department, and some years ago they found out it's possibly not the case that we have a good accuracy in our hospitals in the region. So they came together and brought 20 cases from each of the hospital and analyzed them, and then found out no, the results were not conform with the literature, and there were variations of the accuracy per center. So they discussed the results together and started a prospective registry of all samples. In the region, and a few years later, really, the accuracy increased. So they are now registering every FNA sample. Once a year we have a teaching, and once in a few years we have a symposium with live demonstrations and cases and exchange with the pathologists. We are going to start an expert panel for pancreatic pathology. And in the meantime, the smaller hospitals show better results, and there's decreased variations in results, which is good. So the idea is to do it national-wise, to register every case and then present the results back to the endoscopists, because it will, the feedback will increase the accuracy as well. So I think there are different parts which can be improved. For pathologists who are trained in histology, I think the cell block and FNB samples are better than smears, and of course the exposure of the pathologist and the tradition in the department is very important, but also the pathologist should register the samples in a uniform way to be able to get back and make a good feedback to the clinicians. And we also should make use of the digital world and exchange difficult samples with each other and do this evaluation on a regular basis. Whether or not molecular examination will improve the accuracy, I don't know. We are going to study this, but I hope that some things will change and improve, and in my view, that many things will end up in the fluids instead of the glass. Thank you for the attention.